Welcome to the Medical Support to Irregular Warfare podcast, an initiative to discuss and educate the evolution of medical support in peace, security, and conflict in uncommon environments. Points, perspectives, and opinions voiced here are solely those of the contributors and do not represent any formal association or government entity. We do everything possible to ensure the information and discussion is sound, comprehensive, and from the most credible sources. Ladies and gentlemen, thank you for joining us again on another MSIW podcast. Today's topic focuses what arguably might be a new subject within the realm of operational medicine, and that is crisis standards of care. Much is spoken about the potential challenges we see in both irregular warfare and within strategic competition in major joint operations or large-scale combat operations. Just what types of care challenges, mortality challenges, and how to best prepare for those eventualities, both for the good of our providers and for the good of the patients, especially when considering some of the most difficult theories in medicine here. Colonel Jen Gurney predicts that most care will be given by the least trained personnel in these eventualities. So what? So what does that mean, and how and in what ways do we prepare that for the future? Looking out for patients and providers, here we would like to discuss and most likely introduce, in some ways, the subject of crisis standards of care. And with us today is Dr. David Marcozzi. Dr. Marcozzi had an exceptional career as a medical officer in the United States Army and served with distinction in SOF. He later went on to complete a U.S. Senate Congressional Fellowship, during which he assisted in drafting the Pandemic and All Hazards Preparedness Act, one of the few medical officers to ever serve on the White House National Security Council under Presidents Bush and Obama. Leaving the federal government, he has continued service at multiple state and local health system roles and is presently the Chief Clinical Officer and Senior Vice President of the University of Maryland Medical Center. Dave, sir, welcome, and we appreciate your contribution here.
Sergeant Major, good to see you. Good to see the community. I look forward to the conversation.
Fantastic to see you. Quick question before we delve into the deep subject of CSC. May I just ask you, out of curiosity, because I can imagine how rare it is for a physician to serve on a National Security Council, what was that like?
Well, besides my time in uniform, it was one of the greatest honors I've had to date in my career. And please don't tell my wife. But we had the opportunity to get involved with many complex problems. Everyone there was a patriot trying to work the issue, whether or not it was for Presidents Bush or President Obama. And the challenges there were many, and the solutions needed a collaborative team to try and figure them out. And Mike, I'll just tell you that I was really honored to be there, and know that work really supports the work that all of your community who's listened to this broadcast today, that there's a recognition inside the White House of the exceptional work of our SOF community and, truthfully, the military, our military. It was nice to hear, as a person inside those walls, about the gravity that our community provides and the strength that it provides our nation.
That must have been an incredible experience. We appreciate the work there. All right, sir. The subject is crisis standards of care. I know you have a presentation, but just for a caveman, what are the crisis standards of care and how did they come about?
They've come about slowly. They've come about through challenges that were experienced by providers, by communities, by patients that there were no right answers for. I think that it is bubbled up to a point now where it's starting to get more attention, and folks like you bring that attention to the right leaders. I don't know if we are where we need to be as a nation, as a military, or as communities across our nation. In fact, I'll speak to that a little bit in my presentation, Mike, about how even during COVID, we were trying to figure it out on the fly, and we can be better than that.
Yes, sir. Just from my interactions, it's an evolving subject, a concept worth looking into, and definitely something that should be worked upon for any advantage in operational medicine. And with that, sir, if you would go ahead and serve up your presentation.
So, Mike, yeah, I just want to walk through a few slides just for folks, just to provide some initial context before our conversation. And I think it's important to just appreciate the point you just made that we have to evolve where we are in our military space and our civilian space around crisis standards of care. The importance is our soft community always leads from the front. And as they lead from the front, having open conversations around crisis standards of care to make sure we understand the implications of that moving forward in the environments we're going to be working in, that is critical to our soft community. And then they will champion this much more broadly within our broad military. And truthfully, I think that it'll help our nation adopt crisis standards of care if and when needed. So I'm going to walk through this at a high level and then look forward to the conversation. Quick agenda. I'll talk about and I'll level set on some definitions. What's the background of this is a question you asked me. I'll talk about the pivot, which is really where I want our SOC community to appreciate this move and how do you think differently and what crisis standards of care means. And then I'll talk about some triggers and some operational things. All right, so this is the definition of crisis standards of care. They are justified alterations in usual healthcare operations during episodes of resource scarcity and where we're overwhelmed with patients. It's not optimal care for every patient. It is the greatest good for the greatest number. So what I would say would be crisis standards of care provides a framework for who gets what, when, and why. And it also fundamentally protects clinicians, providers, from improvising in a vacuum where we really don't know and we're trying to make the decisions. It provides an overarching architecture. And that is why I'm glad to be talking to everybody about this. All right, so here's a quick history. There's a lot of roots in triage, or all our wartime episodes that we've had. There's some modern events that have really brought this to bear of what to do when we don't have enough resources. And I'll just say the most modern catalyst has been COVID, obviously. What we looked for when we try to think about crisis standards of care is, are there any groups, any large consensus of experts who think about crisis standards of care? And what I'll reference everyone to, and I'll talk about quickly, is the Institute of Medicine, now called the National Academy of Medicine. It has put some text out there. So if you want some additional reading, I want you guys to make sure that you jump off from this conversation to that for some a little bit more of a mile deep on what crisis standards of care is. COVID-19 was really our first proof test on whether or not we could and how should we do this. And if we try harder, it doesn't work. What we have to do is think smarter about how to think about resource constrained environment and treating patients in those environments. So here's that document that I spoke about. Indications and triggers. Dr. Dan Hanfling, John Hick, all thought about this with a huge group of consensus experts. So this provides the initial toolkit for how to start to think about crisis standards of care. It built on a document from 2009, but this is really some of the first work to try to put on paper what crisis standards of care might mean. Truth is, I think it went to the water's edge. And you're going to hear about why I went to the water's edge, but didn't jump in the pool as much as we needed. And that was highlighted during COVID. Our military community is even starting to publish some work in this space. Look, this is a publication from 2003 of what they are trying to think about, not necessarily to the soft community, but how crisis standards of care can be involved and should be thought about for Role 3 ICUs. And here's a quote. This is important. They quote in this journal that the military health system currently has clinical guidelines for mass casualties, incidents, and triages, but lacks deployed Role 3 ICU crisis standards of care guidelines, and which is a shortcoming and will be tested in the next war. Granted, this was written in 2023. The importance of this is, so we don't even have these at Role 3s. This conversation helps shape conversations on the ground. And that's the importance of the work that you all do. So here's why is Sergeant Major talking to Marcozzi? Well, I've been doing some of this work for a while. And in fact, I was able to be honored to work with Dr. Gabe Kellen at Johns Hopkins to publish in the New England Journal on what we did during COVID in our state of Maryland. And I'll leave with this. Go to the bolded area on this slide. We really, although those IOM guidelines talked about triggers and thresholds, When it became real and we had to make decisions, those guidelines only got us so far, and we had to evolve them moving forward. And that publication that I spoke about with Gabe and I really started to move towards a true operational and tactical model that everyone agreed to. And there was a consistent common operating picture that communities, that families, that patients, that providers all understood that we employed within our state of Maryland. Here's the key, guys. This is a pivot, and this is hard. And I'm going to be honest with you, as an ER doc myself, we think about one provider to one patient interaction. We're going to use all those to employ to make sure that we get optimal care for that patient. The difference is we have to think about population-based measures. Now, population-based measures in the civilian community could be someone with congestive heart failure or someone who lives in that zip code. Well, for our soft community, it's who you've got in front of you. Your population is your unit, is your task force, et cetera, et cetera. So you need to think about how your population, if you have moved towards crisis standards of care, employs decision-making so that we can collectively and broadly think about the health of that population and the resource environments that we have. All right, I'll pause on this slide just for a second. There's a lot on it. Okay. And this is a civilian construct. So I want to be cautious with making sure how do we think through this in the soft community. But there are typically 4 levels to care that we think about. And this was in the Institute of Medicine document. Conventional, you have one for one provider to one patient, the way we do things on a daily basis. Contingency is we start to get a little stressed. Contingency is we can still provide care, but you're going to wait longer, or we're going to do something different. We only have this medication versus the optimal medication, and we can give this alternate medication. Still good enough, not the perfect, but still good enough. And then we move to crisis standards of care. Crisis standards of care is we've got one endotracheal tube for 2 people, make some decisions. Lastly, catastrophic is when you just don't have any, and how do you think about, and so I'm going to leave that one off the table for now and only focus on, for this conversation, crisis standards of care. So what are the benefits of starting to talk about this for us as providers? So quite often when we move towards crisis standards of care, it's done in the fly. We're trying to make decisions right then, and there's really no guidelines. And then after the fact, we're all kind of carry the weight of, did I make the right decision? Should I give that to that person versus this person? And unfortunately, all of us providers carry that weight moving forward in our lives. And I think there's a better way to do this. It also provides legal protections, right? So we all think about did we do it right? But did we do it right not only from our own analysis, but does legal, when it gets reviewed in the back end, does legal say we did the right things from a regulatory and legal standpoint and an ethical standpoint? It provides operational clarity, which is, I think, the strongest bullet on this slide, is it provides operational clarity on what we're supposed to do, how we're supposed to do it, and when. Finally, team cohesion and psychological safety is part of the things we all think about, particularly in our soft community. We're coming together. We're all agreeing this is how we're going to employ crisis standards of care. And this team, us as a group, we all agree that, yes, that's what we're going to do moving forward when we get into some of these situations. And that is something so we don't have to carry it forever, go moving forward. This slide is really important for those leaders on this call who are listening in. I'm going to pause. Take this away from me. We as leaders need to make sure that we are starting to have these conversations. My question to all of you is, if you are a leader on this call and listening in, what conversations are you having around crisis standards of care? What policies do you have? Have they been vetted? And are they up to date? Crisis standards of care is not triage. Crisis standards of care is an overarching architecture when there are resource-constrained environments that you have to treat the numbers of patients you have in front of you, that you can't sufficiently have a one-to-one conversation. It's a one-to-many conversation on how do you think about that population. And that starts with strategic level conversations. Then you move to operational level. The providers on this call, how do we think about that policy and making it action-oriented to thresholds at the operational and tactical level. And that's exactly what speaks to that COVID article that Gabe and I had. We had kind of strategic and operational constructs, but when we got to tactical level decisions on the ground, The state of Maryland didn't have it during COVID-19. And that's what I want everyone to evolve to. There are 3 levels that I think we all need to start to work on to get to a better place for our nation and our military. Look, last bullet, if you look at the bottom, our cardinal rule should be providers, clinicians should not be implementing CSC on the fly. It is not designed in real time. It is done through thoughtful, collaborative, engaging conversations with multiple stakeholders to get to the right place. A couple things that the tenets of crisis standards of care is important. I'm not going to read this slide. Just go to the left. There are ethics involved when we move to crisis standards of care and who gets the care and how they get the care. Those tenets that you see on that left-hand side are fundamental to an equitable approach to patients that are in front of us when we're in resource-constrained environments. And that's key. So when we walk away, we go, we did the right for the many in that situation, and that's important. We all are very familiar with this, right? Red, yellow, green, and we move to black. Any crisis standards of care conversation would not be sufficient unless we talked about this. And I'm going to just pivot to this category, black. Remember, everyone on this call, and I think we all do, if we were into black tag on any of our patients in front of us or casualties in front of us, that does not mean they're forgotten. That means they're transitioned to palliative care. They're supported because we don't have the resources to provide for them at that period of time. So remember that, and in this conversation needs to make sure whenever you move to crisis standards of care, you think about how to assure that our casualties are supported during these challenging times. So we have challenges in the military and security constructs. And if you go to, why are these, we're familiar with triage. Why aren't we familiar with crisis standards of care? Well, all of our SOC community, it's mission first, never fail, right? This is how we do things. So if you have that construct, we're never going to fail. And crisis standards of care conversations is really challenging. We really don't know who declares it. Is it the task force? Is it the team? Is it the unit? At what level do we think about this? And this is why those 3 levels of strategic, operational, and tactical come into this conversation. That should be laid out in advance, not done on the fly when we're in the middle of the fight. And then lastly, there's those complexities of, when we're in the fight, what are those complex? How does legal think about the review of this crisis standards of care construct? So I want to just make sure everyone knows this is hard conversations, but these are the right conversations to have. In the irregular warfare world that our SOF community works in, this is why it's important for Sergeant Major and folks who are championing this conversation to move forward from a podcast to operational employment and common conversations, is because of these specific bullets moving forward. We're isolated. We're working austere conditions. These civilian military construct is always blended in the worlds we work in. We have multiple different acuity levels and complexity of care levels from only a few hours to potentially days where we're continuing to treat patients versus the rucksack we've got on our backs. And how do we think about doing that in some of the environments we all work in? All right, I want to just make sure you all hear this from me. Our medics, our providers should not be carrying this weight on their backs. It's up to us as leaders to have these conversations right now. And in fact, I have been involved in many exercises through my career. And we quite often, when we get right to that level of when we start to think about crisis standards of care, somebody calls index. So we never really get to the point of, and now what would we do? How would we do it? And what conversations are the right ones? And it's up to us to think about policies, protocol, TTPs, to make sure that we build this construct in place, just like we do for any other skill or any other domain that we work on in the military environment. So Mike, I'm going to leave you with some questions here for this group, and I hope that they take away from it or we talk about it further. Who makes the call on CSC? How do we make the call? Who starts the conversation? Is it the senior medic, the senior medical officer? But maybe it's the commander. Every level has different constructs to it, and it's important that we think about the up and the down on how we make sure that CSC is a conversation, but there's no universally accepted answer to the questions I'm raising here. Here's my last slide, Mike. I'll go to everyone on this slide, go to the bottom, and then work your way up. But this is our uncomfortable conversations. It's important we get ahead of it and not behind that wave. And the conversation I'm on right now with Sergeant Major and I, thinking through how we evolve crisis standards education where we are today, in a year from now, we need to be in a better place. Mike, thanks very much for the invitation. I look forward to the questions that we're going to have follow up.
Perfect, sir. We're approaching my favorite time with you, and that's a discussion. I just want to get a little bit of back and forth here on some thoughts that I had listening to your comments, sir. A curious question here. Is CSC an evolution of triage?
Mike, it's a great question. CSC and triage are overlapping priorities. But there is a evolution, and then when we move from triage to CSC is when we are in an incredibly resource constrained environment. That when we move from triage to CSC, there's no longer the ability to think about individual care. It's about population or group care.
That drives me just to my thoughts. As a caveman, a former NCO, what I love about this concept and the evolution of this concept is that it looks out for our providers, no matter if they're a medic, a surgeon, a physician, whatever the case may be, and it gives them a concern for their mental well-being, their objectivity in these decision makings, and a little bit more of an infrastructure in these decision makings. Would you agree with that?
It does. In fact, this is quite often, Mike. I'm willing to bet in the world you worked in when you were wearing the uniform, you had to make these decisions in real time, right then, to the best of your knowledge and the best of your expertise. Well, I think we can do that better, and I think that with the wisdom you have, can help chaperone that moving forward for our communities.
Yes, sir. A little bit of a recap, and I appreciate your patience with that. Sir, metrics. What are the metrics of success with CSC that you see right now?
Yeah, it's a great question. So I'm going to step back, and I'm going to think the first success that we can have is having open dialogues. When we start having open dialogues about CSC, first step in the right direction, right? Acceptance that we have a problem and we need to think through how that evolves for our military, our soft community, our military community. Number two, a success would be that we start to see policies inside DoD around CSC. Number three, there are triggers and thresholds that up and down, all ranks, all communities know about, and then can take forward into their operational and tactical environments so that they have a backstop, so that they know how to employ CSC if they were able to get in those resource constrained environments.
Dave, sir, we spoke of this before, and I want to ask this question just kind of to round this out. One point here is how can we and how could we transparently communicate how we will use CSC in the future?
Yeah, I think it's important. A couple of points on this one, Mike. First, I would say you have to start with the why. Why are we having this discussion? This is happening in our soft community through the years, and we can be better at this moving forward. That's the why. Second is who do we need to engage in this? We don't only need to engage our teams, our provider, our soft community. We need to engage families. We need to engage parents. We need to engage team members. We need to engage the military community and outside the military community to make sure we're doing this right. And then lastly, it's the what. The what is on the ground. How do I employ this to make sure everyone has a common operating picture on how this will be employed, the decisions that were made, so everyone can feel comfortable that in these resource constrained environments, we all collectively went in as a group and endorsed the approach moving forward.
And Dave, sir, that's an exceptional quote right there. Common operating picture, because that links the operational, the medical, and the soldier, sailor, airman, Marine all in one. Sir, thank you. This has been a fantastic discussion with great energy, great expertise, and great education. I just want to make sure I note to yourself and to the audience that we will state and give some information on your and Dr. Callan's work, criteria for declaring crisis standards of care, a single uniform model. We'll post that in the podcast notes. And it's a great stepping off point if you are unfamiliar with CSC. Dave, sir, Dr. Marcozzi, thank you for your time and for your insight today. We appreciate your continued impact both within the community and in your systems there. Best to you and to your family, sir.
Sergeant Majors, it's really an honor to be on this podcast with you. Your wisdom and carrying this forward as a champion to have conversations outside of this podcast is so important. I stand ready to support you.
Have a great day, sir. Ladies and gentlemen, the very best to you, to your work and families, and to our efforts in solving these very complex medical and operational challenges for Irregular Warfare. One alibi please before we close. We would like to remind the community that the annual Special Operations Medical Conference is taking place from April 27 to May 1 at the Convention Center in Raleigh, North Carolina. The theme of this year's effort is Medical Mobility, Empowering Soft Effectiveness. Included will be laboratories, presentations, and panels in separate specialty tracks on topics ranging from surgical care to traumatic brain injury and international medicine. Of note is our own day-long track on medical support for irregular warfare on Thursday, April 30, featuring panels and speakers on allied perspectives of MSIW, medical ethical dilemmas, creating capabilities, and MSIW enablers. We hope you will join us in this trademark event. Thank you. Thank you for listening to this MSIW program, and we hope that you will both participate and contribute to the notes or offer thoughts, requests, and suggestions via our email link. The best to you, your work, and the relationships and security this effort strives to impact.